In terms of envisioning the biggest challenges, one would be well informed to compare the day-to-day emergency with what would occur in theater. And there are several very significant differences. When there's an accident in the day-to-day life we have at home, there's usually a road or an access that's modern. Whereas in theater, the access can be very remote, very difficult to get to. Add to that the very significant difference that someone is shooting at you. In addition to that, consider that when an accident occurs on a day-to-day basis as we know it within our country, it's one system. It's one language being exchanged among the providers. Whereas in theater, you have the scenario of a coalition. And that coalition could involve numerous different nations providing some aspect of that care. And when they do, the exchange of that information should be very seamless so that it's quickly relayed back to where this injured individual will eventually be delivered, will help with anticipating what needs to be done. And so when the injured individual arrives, then the care is expedited. It's more efficient, it's more comprehensive.
Together with ACT, the NATO C3 agency has developed the concept of MEDICS. MEDICS is the Medical Information and Coordination System of NATO. And it consists of 5 pillars, which are medical planning, medical management, clinical support, medical surveillance, and medical intelligence. The day-to-day management of medical support in theater is covered in the medical management pillar. In that pillar, obviously, the management of patients on alliance level has the highest priority. Therefore, we developed with subject matter experts an application that we call MEDwatch.
I think MEDwatch is potentially going to be the most important element within MEDICS, because whilst MEDICS as a whole will provide the planning and the management information, what MEDwatch will do is it will deal very specifically with the needs of what happens immediately after an injury, and most importantly serious injury, occurs on the battlefield.
We're still taking indirect, we're still taking small arms. We have to get him on the bird as fast as possible.
At the moment, when injury occurs on the battlefield, a lot of information is generated. It is moved very quickly, and it is all moved into very busy operational headquarters. The sad fact of life is that when injury occurs, it is usually as a result of enemy action, and all of the issues involved with enemy action, where they are, what is going on, also have to be detailed and processed at the same time. At the moment, all of that information regarding the casualty is coming in from multiple sources, and it's all having to be processed by the medical planning staff.
At NC3 and during various exercises, we have analyzed the medevac processes, and by doing so, we have identified how we can improve those processes by creating functionality to, first of all, speed up the processing of 9-liners and other medevac requests and reduce human errors in that process by automating the transmission of those 9-liners using a special 9-liner inbox. Second, we want to make better use of these scarce evacuation assets by providing interoperability with medical reporting systems so that the medevac planner can better and quicker assess the status of those assets when he's planning the medevac. Then, we want to realize a better treatment and care for patients by automatically disseminating patient information to the medical treatment facility and other locations well before the patient will arrive at the treatment facility. Now lastly, we also want to create a more accurate and detailed recording of the medevac with a graphical user interface that provides the user with a lot of assistance when he's entering data, and by providing interoperability with other deployed information systems.
Medic!
Medevac request, over.
Roger, over.
The sad fact of the recent years is that NATO and our member nations have achieved a great deal of operational experience in very testing operational circumstances. We have learnt a lot of lessons, but that has meant that the delivery of healthcare on the battlefield is of a standard never before seen in military medicine. That high standard of delivery of care now needs to be coupled with a high standard of information management within NATO.
And the bigger question, which is, well, what does the knowledge of this injury, when you consider it occurring to 100 different soldiers, sailors, Marines, airmen, what does that do to change the type of care we provide? If you have a database that is standardized in its data entry, and one which many nations can participate in, and if you can anonymize it so that the names are removed, you can use that information to statistically analyze what is the significance of any change in care in terms of changing what everyone should do.
Now, MEDwatch can also help in the analysis and lessons learned processes. For example, by storing all data in the database, statistics can be easily generated on, for example, the amount of patients, the amount of specific injuries sustained, or what kind of treatments have been provided to the patients. Now, secondly, by recording exact details on who made what changes and when, a very detailed audit log for MEDICS is created, which can then be used as a legal log. Now last, by providing input to the common operational picture, such as locations of injuries and details on the movements of patients across theater, situational awareness can be improved.
This database will lend itself to a statistical analysis that could justify changes in the standard of care. And that has been the case without the database only on a rather slow basis, on a group of providers sitting down and saying, well, we tried this with various fluids delivery. We tried this with tourniquets. And one gets some indication of justifying changes in care, but a statistical analysis is much more powerful and can justify significant changes in how care is delivered, or how technologies were or were not successful to enhance care.
For me, the most important element of developing MEDICS, and MEDwatch in particular, is that we do it in conjunction with the people who will use it in the field.
B0, C3.
This has been a constant theme of the development work over recent years within NATO. And as we prepare to refine MEDICS and MEDwatch, we continue to engage with the operators. NC3 Alpha, for me, has done a wonderful job throughout this project. It's particularly important within MEDICS because this has been a project that has been ongoing for a number of years, far longer than the average length of service of a military officer such as myself within the NATO command structure. So what NC3 Alpha has provided, and provided very well, is that collective memory, the memory of what has gone on, and the memory of what needs to be achieved in the future.
Charlie 4, прием на един пациент в рол 2 medical treatment facility.
We're very excited about the development of these products, and in terms of the need in the field, it will enhance an international, if you will, or internation medical interaction. It's going to be a step up from what we currently are able to do, which, as I mentioned, remains a standard of care that was never equaled before in any conflict. So we're working with an excellent level of care, and we're looking to refine it even more.